Hi, everyone. Hope everyone is having a great day. Big thank you to Jason Zucker for an amazing presentation. So today we're going to be talking about PrEP options counseling, which is a new way of thinking about PrEP now that we have so many amazing options for patients. I have no disclosures, and here is our PTC disclaimer. So for the agenda today, we're going to go through a little bit of HIV epidemiology, so you guys know where we stand. Then we're going to go through PrEP options counseling review. Oral daily regimens are still available and great for patients. PrEP on demand is still something that we can offer patients as well. Cabotegravir injectable or Apretude, and lenacapavir injectable or Yeztugo. Then we're going to talk very briefly about navigating cost and coverage for these PrEP regimens and touch on monitoring and retention, and then we'll hopefully have time for questions. All right, so this data is a little old from the CDC, but it was in 2022 that we first started seeing an increase in HIV cases nationwide. Obviously, the goal is to decrease HIV diagnoses, but in 2022, we saw a rise after COVID of a 5% increase. And this has kind of continued since that time, unfortunately. So to identify gaps in HIV prevention, we're going to look today at the PrEP to need ratio, which is right here. This compares the number of people using PrEP to the number of people newly diagnosed with HIV. And this shows how well PrEP usage aligns with the need for HIV prevention. So a lower PrEP to need ratio indicates a more unmet need in that population for PrEP. So this is a shot of the states showing the PrEP to need ratio. So the darker the color, these are the number of people using PrEP in 2024. This data comes from Emory, and it's available for anyone to drill down on their location from the AIDSview website, which is listed below. So you can see in New York, the number of persons using PrEP is a dark green color, indicating that we have a large amount of people using PrEP. But then kind of to see where the gaps are, we need to look at key demographic groups and where we're missing interventions around PrEP. So as you can see here, the areas that have the shaded gray bar that's higher than the folks that are on PrEP would indicate a population of people that we are continuing to miss when educating on PrEP and making it available. So that would be women, younger populations, as well as Black and Latinx identifying folks are groups that would benefit from a tailored PrEP education and also provided with all the options that we have for PrEP. I know this data now is a little old because we just got the full 2024 data, which came out on World AIDS Day. Unfortunately, in New York City, we did see a 5% increase in HIV cases. There's no better time than now to start talking to patients about their PrEP options and consistently doing this across New York City and across the US. The neighborhoods in New York that have shown to be the highest rates of new infections are the South Bronx, Upper Manhattan, and neighborhoods in Brooklyn are the highest new infection rates that we're seeing. And this is kind of the PrEP to need ratio just broken down in New York, showing the percent of PrEP users versus the number of new HIV diagnoses. So you can see here, again, Black and Latinx folks are drastically missed as far as provided with PrEP, but they are the bulk of the new HIV infections that we are identifying. So PrEP options counseling. This is Sam. Sam is a 19-year-old African-American male. He presented to our clinic 3 times in 2014. He was one of my first patients when I came to Columbia. Excellent student, very involved parents. He reported multiple male sex partners that he met online weekly. During each of his 3 visits in 2014, Sam had rectal gonorrhea. Our team met with this patient a year after he was first seen at our clinic and sadly had to give him an HIV diagnosis. You know, there's a lot of things different in 2014, but a lot of things are still the same. If we had offered him PrEP at any of those 3 visits where he came in for rectal gonorrhea, maybe things would have been different. Sam is doing fine. He's undetectable. He's living his best life, but we could have prevented this chronic illness back in 2014. So this is Jane. Jane is a 27-year-old female who started her care at NYP in January of 2024 to confirm her pregnancy. She was due in October of 2020. She had had her two full-term pregnancies. They were normal vaginal deliveries. She reported one male sex partner at her first visit for this pregnancy. Her initial OB appointment, as per the guidelines, she was tested for HIV. Her partner was with her when she was tested. At her third trimester appointment, again with the guidelines, tested negative for HIV. Her partner was with her there as well. She had a scheduled induction and normal vaginal delivery, and the newborn screen in New York State is set, or they do a newborn screen at birth in New York State, sent it to test for HIV and other diseases. So she went to City MD in New Jersey. She received the newborn screen from a call from the state saying that the baby had antibodies for HIV. So then she went to City MD in New Jersey and was found indeed to be HIV positive along with her partner. So what could have been done differently? I bring this case up in comparison to Sam's case because sometimes we get frustrated by how little movement we've made in these areas. I think one of the things that we could have done differently in this case is the partner was there having conversations with the partner or with the patient about the partner and their HIV status would have been helpful. Having a frank discussion about sexuality during OB visits also could have been helpful for this patient. And offering, regardless of what you think or presume is happening in the relationship, making sure this patient and their partner are aware of PrEP and that it's an option for them, I think is something that we could have done different. Okay, so the CDC guidelines in 2021 indicated that all sexually active adults and adolescent patients should receive information about PrEP. Regardless of what you think is happening in their sex lives, regardless of a sexual history, if they ask for PrEP or if they say they are sexually active, a conversation about PrEP is recommended. So they also included this algorithm to show, to drill down a little bit more, like who should specifically be talked to about PrEP. But if you'll notice at the bottom, light green and green boxes, it does say discuss PrEP with everyone, regardless of the answer to any of these questions, and prescribe if requested. I think everyone, I don't know if anyone saw the Canadian PrEP guidelines came out yesterday, and they really emphasized this. If a patient is asking for PrEP, regardless of what they're saying is happening in their sex life, it should be offered. I think everyone is coming to realize in a real way that patients maybe aren't so comfortable talking about their sex lives to providers. If they are, great. If they're not comfortable about talking about it, they still should have the option of having PrEP on the table as things that they can start. So I should talk to everyone about PrEP? Yes, and here are some tools in which to do that. So this is our PrEP options counseling flyer. You are welcome to it. It is free and on the internet. The Blueprint website is listed below. So here is what we go through with patients when we're talking to them about PrEP. And the goal here is really to universalize PrEP education, and with the understanding that this reduces stigma and reluctance of initiation. So in order to truly provide a patient with HIV prevention choice, a provider should review the impact of each choice. So each of these on this list, and each choice's impact on physical, psychological, social, financial, and financial well-being. So condoms available, protect you from STIs, including HIV and pregnancy, reduce the risk that the condom will break by using plenty of lube, available to you. Daily oral PrEP, love a routine. PrEP can be offered daily, and we'll go through each of these. 211, planning to have sex but don't want to take a daily pill? Let's talk about 211. Non-penetrative play, pleasure your partner, doesn't have to involve anal or vaginal sex, but keep in mind some STIs can still get passed without penetration. Injectable PrEP, the new kid on the block, long-acting medication stays in your body and gets re-upped at each injection every 2 months or now 6 months, which we'll talk about. And PEP, were you exposed to HIV but didn't have protection? Start post-exposure prophylaxis up to 72 hours after your sexual exposure. So potential and current PEP users have the right to fully understand the pros and cons of each of these methods. And one thing we go through in each of them is side effects. So long-term and short-term side effects, potential drug interactions, cost, both financial cost, but also the time that's spent to acquire this medication. Logistics, testing, and visit schedule, and implications for stopping and switching methods. Um, Before I go into each one of these, I'm going to break them down. I usually start with a patient with an open-ended discussion about their sexual health goals. And so this way we can start from a place of sex positivity, where the patient can express what's happening in their current sex life, and we can see where PrEP can fit them in, where PrEP can fit in to achieve their ideal sex life and also ideal quality of life. So potential and current PrEP users have the right to fully understand these pros and cons. Okay, oral daily PrEP. TDF-FTC or Truvada, and TAF-FTC or Descovy. So Truvada FTC, we have brand and generic. It's available and recommended for anyone. It can be available daily or on demand. The guidelines, the studies that were done around on-demand dosing, approved on-demand for MSM only, but we can discuss that in a little bit. Truvada or generic TDF-FTC, we've seen it available for $30 a bottle, sometimes $16 a bottle, depending if you get maybe 3 months in a row. It is been well studied and is 99% effective if taken correctly in preventing HIV, and available. Descovy or TAF-FTC, we only have the brand. It's been studied and approved. There's limited data around folks who were assigned female at birth. It's only available daily, and it's a smaller pill. It is a bit more expensive, but we'll talk about that in a little bit. Both are approved for adolescents and adults. Both are effective after 7 days in protecting against HIV for anal sex. We'll talk about the 21 days for vaginal sex. Usually for folks that are starting Truvada or TAF-FTC or TDF-FTC or TAF-FTC, we recommend they take 2 pills the night after they leave our clinic with a big meal, and then start taking it daily after that to jumpstart the protectivity. Both of these medications, we recommend follow up quarterly for testing with a and both are 99% effective in preventing HIV. And here are the various bottles that you'll see, specifically the way that the generic bottles looks. There's a lot of different vendors for generic TDF-FTC that you can find. All right, so this was a study conducted on the heels of Gilead's lenacapavir trial. One of the arms of the trial looked at TAF-FTC and its effectiveness for those assigned female at birth. It did show equal protection for folks that were assigned female at birth taking Descovy. Because of this study and the results from the study showing its effectiveness, Gilead's Advancing Access Program, which provides free PrEP to folks who are uninsured, has now made Descovy the only drug available. So for cis women, we are kind of tied if they are uninsured to provide Descovy. The results aren't, they're not as conclusive as the TDF-FTC trials around cis women, but it's what we have at this time. And I think we'll see more that it works just as well. We just don't have the 20 years of data to back that up in the same way. On-demand dosing. So the definition of on-demand could be anything, basically not meaning daily dosing. So taking PrEP, specifically TDF-FTC, around the time of a sexual encounter or a riskier period. TDF-FTC is the only pre-exposure medication that's been studied in on-demand dosing. So that's the one we recommend for folks. It was studied in the eBrigade trials with men who have sex with men. So if you have sex more than twice a week, you're just taking it daily. So you should probably just take the 1 pill once a day. And still adhering to quarterly visits is very important for everyone, but folks who are taking on demand. Okay, so the exclusion criteria, individuals engaging in vaginal sex, we'll talk about that in a second. IV drug users, on-demand dosing was not looked at in folks who were using IV drugs. Adolescents, just because of the having to know when you're going to have sex 2 to 24 hours before you have sex, adolescents sometimes have difficulty with this schedule, but it could be a great option for folks if they can get around the fact that they have to remember to take 2 pills before they have sex. Individuals engaging in sex more than twice a week is an exclusion criteria just because you're taking it daily. And individuals taking TAF-FTC or Descovy would have to switch to TDF-FTC or demand. And here is New York City's graphic for on-demand dosing: 2 pills 2 to 24 hours before you have sex, 1 24 hours after, and 1 48 hours after that. And here is ours. So you go on Grindr, you take your 2 pills, you get ready to go, and have some sex 24 hours after that and 48 hours after that. One question we get all the time is, what do I do if I keep having sex? So you're basically taking it daily, and just make sure to take 2 pills for 2 days after the last time you have sex. Understanding this is complicated, but providing patients with a graphic is always helpful. But we have folks, go to Fire Island for the week, take 2 pills on the ferry, have some sex all week, take PrEP every day, and then take 2 pills when they get back the next 2 days. So this was presented at CROI last year, well, this year, but looking at PrEP on demand for women. And I think the more important takeaway here is we've had this thought from the start of the PrEP movement that women had to be super adherent to PrEP every day. Don't miss. It won't work if you miss. I think what this showed is that PrEP does work for cis women, or for assigned female at birth, even if they're not perfect. Shocking. So while emphasizing that although daily adherence is important, a minimum of 4 doses per week of TDF-FTC is expected to provide effective protection for most females. So this was a study presented as well, showing what on-demand dosing could look like for women and what that protection level looks like. So the one that was recommended at the end of this presentation was 2-1-1-1, because that's the least amount of pill burden and also something that could be remembered easy. So this is an opportunity for shared decision-making with your cis female patients or your assigned female at birth patients, to be able to talk to them about, okay, so PrEP daily isn't realistic for you. Like, does injectable make sense? Does some version of on-demand make sense for you? Understanding that we don't have a ton of data on demand for women, but we do have some guidance shown in these studies. All right, long-acting injectable cabotegravir or Gabapentin. So this medication came out in 2021 from the results of 2 large-scale efficacy trials, and it found that injectable cabotegravir or Cab-LA, given every 2 months, was as effective as the oral form of pre-exposure prophylaxis. They did a really good job of including diverse populations in their studies, and it was approved in December 2020. So the window period for injections is you receive an injection the first day, and then a month later for a loading dose, and then every 2 months thereafter. There is an option for an oral lead-in medication, which we honestly have never used in any of our Cab-LA patients. But if you're worried about tolerance or side effects from a patient, there is an oral lead-in option for a patient for 30 days prior to starting the injections. It comes from a different company, so that logistically it's pretty difficult to obtain, but it is possible. So these are the educational points when I'm doing my PrEP options counseling with a patient that I go through prior to ordering the medication. Ordering the medication is a whole different beast. First, we go through this to make sure they're really interested. So the dosing schedule and importance of a window period. So you have 1 week on either side of your injection date to receive the medication. So for folks who travel or who go away to school or various other things, there's a lot of things that can get in the way of them coming in every 2 months. Is this a realistic thing for them to make this commitment? The site of the injection is luteal. A lot of patients, once they hear this, are like, no, thank you. But make sure to tell them before you order the medication or before they show up for their injection, so they're not surprised by the fact that they have to reveal their tuchus. Medication tail. Okay, so this is something it's difficult to describe to patients. We have a video on the Blueprint website that you're welcome to look at and use with patients for patient education about the tail. I think it's important for patients to know why we care so much about them adhering to their medication. So I think it's an important education point. It's just difficult to communicate. So basically, you get your injections, you're going along fine, and you decide Cabolet is not for you, there is a unknown / significant level of Cabolet that remains in your body for up to a year after the last injection. So this is just a graphic to show when the level of Cabolet drops below this line, you're at risk for getting an HIV infection that possibly could be resistant to cabotegravir or the integrase inhibitor class. So what's recommended if you're going to stop is that you need to add a level of protection during that time. So what does that mean? Could mean taking TDF-FTC daily on demand after you stop your Cabolet. Could mean using condoms. It could mean abstaining. Just to take into account that the medication is still in your body for up to a year after the last injection, I think is an important point for folks. So also in the clinical trials for Cabolet, they showed that there were some depressive symptoms in folks who were receiving cabotegravir. We've started about 100 people on cab. We've had 2 or 3 people say they felt more depressed while taking Cabolet. There's a lot of confounding factors that could be involved in that. But I think making sure patients are aware that this could be a side effect if they have a history of depression, making sure they have support in place in case they do feel more depressed on this medication. All of those things are important to make sure a patient is aware of. All right, new kid on the block, lenacapavir injection, or Yeztugo is the brand name. So this was approved in July of 2025. It is a capsid inhibitor, which is a new class of drugs that we're using. It is delivered via 2 subcutaneous injections in the abdomen every 6 months. It's been used since 2022 as a part of an HIV regimen for positive patients with multi-drug resistant virus. So the good thing about this is that if you were practicing in a HIV clinic or a place where HIV patients receive their care, the nurses probably are already trained to receive this medication. The series of trials conducted by Gilead were called the PURPOSE trials, and they demonstrated to reduce HIV infections by 100%. They also were very intentionally diverse in their study populations, which was amazing because out of the gate, we could start providing it to everyone who was in the trials, which is everyone, including adolescents and folks with uteruses who could possibly have babies and had babies during the trial. So this is the first time we've had a clinical trial like this where we've had data on pregnancy at the outset. So the conclusions in all the trials were that specifically the ones involving cisgender adolescents and young women, twice yearly subcutaneous lenacapavir was superior to TAF-FTC in preventing HIV infection. The biggest side effect in these trials, not surprisingly, was the nodules or the site reactions. So len is injected into the subcutaneous space. We're going to talk about this a little bit. It forms a drug depot that may be palpable under the skin, but it's usually not visible. And the nodule emits the drug over time, and the nodule reduces in size substantially before the next injection. So a significant portion of people experience the nodule, not everyone, but most people, and did cite this as a reaction during the trial. Okay, so when discussing len with a patient in my options counseling, I here are some of the educational points that I go through with the patient. So I start with the discussion about the nodules because that's the biggest thing that people are worried about. It's super important that patients are aware they could experience this, but also 35% of folks receiving lenacapavir don't experience a nodule. So you want to make sure they understand that if they don't have a nodule, that's also not something to be concerned about. Okay, so this is the box. This is how it comes, and it also is recommended to give these pills at the first injection. You take 2 of these pills. I should have put something to show you the size, but they are very large. They're not small. So I've definitely had patients who were like, oh yeah, len makes sense. I want len, no pills for me. And then they show up and they have to take these pills. That could be a reason why somebody doesn't want to do this medication. So they take 2 pills the same day as their injection, and then 2 pills the day after 24 hours after their injection. Okay, so here's a short video of our first injection. This is a lovely patient of ours who was on cabotegravir for years with us and was very excited. She travels for work. It's hard for her to come in every 2 months, but she is a no pill person. So this is obviously not an injection education video. This is just to show you because I really wanted to see what it looked like before I gave it, just so you guys can see. I just want to note how slowly Jen, our nurse, is going with injecting this. That's intentional. She's also squeezing the skin. Just to say, I'll talk about that in a second, but why she did that. And that would mirror on the other side. And if you heard the volume, I'm basically saying, does this hurt? And she said, I didn't even feel it. So it's a good sign. There you go. Yay. So here's a video from Gilead showing the reason for the nodule. If a patient wants to see, this is a great opportunity to show them what the nodule is doing. So throughout days or weeks, lenacapavir is releasing into the bloodstream. That's why you have a nodule. So leakage. This is that same patient's belly. So since lenacapavir is a long-acting medication and it's very viscous, some leakage may occur. So a small drop is normal. It's common to see a small drop of medication or medication tinged with blood at the injection site. Most patients say they've seen this. If they don't see it, it's still okay. But the patients who do see it, it's important to educate the patient during or before that if they see this, does not mean that they are leaking the medication out of their body, or that a dose was lost, and this is not a cause for concern. So the reason why Jen went so slow is slow injections of viscous medication can reduce the leakage. She also waited before removing the needle. This can also be really helpful to prevent medication from leaking out, and just applying gentle pressure after the needle is removed can also help seal the injection site. So the injection is in the belly, the subcutaneous belly, but also the thigh is up for grabs. This is the package insert from Gilead's from the medication, showing that the thigh was used in the clinical trials as well. Also, the sides of the belly are also up for grabs too, if the patient would rather have the sides. So making sure that the patient knows that these options are also on the table. We've had patients say, there's no way I want a nodule on my belly. The thigh could be an option for you. The reps from Gilead are saying that also what's being looked at is under the arm for lenacapavir, but that's not available right now, maybe in the future. So the 90-degree insertion is important as well. And you have to make sure that the second injection is at least 4 inches from the first site. So if I'm seeing a patient today who wants to start on PrEP and I'm doing my PrEP options counseling and they're interested in long-acting medication, but more importantly, they're there right now and they want to start PrEP right now, I have to make sure to paint a realistic picture of the timeline for this patient to get their medication. So the turnaround for Carnevale, give or take, is about 3 to 5 days. The patient's insured and we have everything we need. For Len, in the 10 people we've started, we're seeing about the same. But we don't really have a good picture from all the payers for lenacapavir. So I think the point really is if somebody wants to start PrEP right now, waiting to start, if they're willing, I think starting somebody on an oral regimen when they're right there in front of you is super important. Not only will they be protected while they're waiting for their injection, but they also received what they wanted from their visit with you, from their sexual health visit. So giving somebody TDF-FTC or TAF-FTC while they're there or like upon leaving, I think is an important thing while they're waiting for their injection to arrive, if they're willing to take it. So the schedule of 2 initiation labs, this is New York City's AIDS Institute clinical guidelines. So they want a laboratory-based antibody antigen test within the past 7 days if you're starting lenacapavir. For same-day initiation, I don't know anybody who's able to do that right now, but hopefully in the future, who knows? A rapid HIV test plus a laboratory-based test is required. An HIV RNA negative assay would more confidently rule out acute HIV infection for folks that may be reluctant to disclose their behavior. So for initiation labs, an RNA test is not required unless you're switching regimens from another PrEP regimen or you're switching off onto pills. We don't require HIV RNA testing unless you're worried about acute HIV infection or you're switching regimens. They're recommending HIV testing at every injection visit. And we also are considering and heavily considering interim 3-month HIV testing for high-risk individuals receiving LEN every 6 months. For the HIV RNA test at the injection visit, if you are bridging, or if you're worried about acute HIV infection, and then gonorrhea, chlamydia, and syphilis testing every 3 to 6 months based on their report risk. So these are the drug-drug interactions with lenacapavir, which I think is super important to educate patients on before starting and before considering lenacapavir, especially this one. So this is showing a potential side effect with erectile dysfunction medications. So this is Viagra, Cialis, Levitra. This is due to an inhibition of the CYP3A4 by LEN. So it enhances the effects of the erectile dysfunction medication. And we can see with this prolonged and painful erections lasting more than 4 hours, cardiovascular issues like chest pain, irregular heartbeat, or low blood pressure, sensory changes, including visual disturbances or hearing loss. So the long short of it is we're not sure what this looks like, or if you cut your dose or you take it less frequently. We don't know. So I had a patient last week ask me, they told me they take Viagra every day. And can they take LEN? And I told him about the interaction. We had a long conversation about what might happen. I think that maybe if he took it less frequently, maybe he wouldn't have this as much of an adverse effect. But we don't really know yet. So I think having a very frank conversation with patients about what might happen if they are taking lenacapavir and decide to take any of the erectile dysfunction drugs is super important. And for people who rely on this or take it from friends, or maybe they aren't being prescribed erectile dysfunction drugs from you, but they get it from AAHIVS or something online, I think it's really important to make sure they're aware of this. And the other one is ketamine. So ketamine concentrations may increase again due to the inhibition of the CYP3A4 by LEN. So it may increase the side effects associated with ketamine. And this could be profound sedation, central nervous system depression, respiratory depression, cardiovascular issues, potential for overdose on the ketamine. As ketamine is being used more frequently for chronic depression, I think it's really important to have a conversation with folks about the ketamine interaction. And also for folks who are using ketamine or are using drugs that maybe are coming from a club scene or an environment in which they're not sure what is in the drugs. I think a really big, frank conversation about drug-drug interactions. And there are ketamine strips available. They're prohibitively expensive, but that could be something that we could explore in the public health community for folks. I do think this is something that needs to be taken seriously with our folks who are using drugs, as they might not know that ketamine is in the medication they're taking. So the tail, we talked about it with CAB. What is a little different here with LEN is, as I mentioned before, lenacapavir is a capsid inhibitor. So here are the things we know about what lenacapavir resistant or a lenacapavir resistant virus would look like. So there's no indication as of yet of cross resistance in patients who develop a capsid inhibitor resistance. So the thing we're worried about with cabotegravir is you're blowing a very important class in an HIV regimen, which is the integrase inhibitors. Lenacapavir associated resistance mutations are very rare, therefore it's unlikely to be transmitted for patients receiving LEN for PrEP. And capsid inhibitors are not included in a first-line regimen for HIV treatment. So, while we think about how LEN can make a difference in access for people who have not accessed PrEP previously, I think being a little bit less cautious of or less concerned about this idea of lenacapavir resistance is an opportunity for us to give it to marginalized populations that maybe don't have access to PrEP in other ways. I'm thinking like drug using populations, folks that aren't as likely to come back into clinic every 2 months, and every 6 month PrEP injection for somebody who is not so great with coming in or keeping their appointments. Maybe this is something we should explore as a public health community as an option for folks in a more broad way. So unanticipated and anticipated bridging. So this is when folks are like, oh yeah, I have my appointment in March for my Len, but I'm going to Bermuda for 3 months. So these pills that I showed you earlier, they can be used for bridging medication. It's 1 a week. So you would take one of these tablets once a week while you are waiting to get your next injection. I don't know how available these are going to be for everyone. I know right now they're not super available. You can also use TDF-FTC to bridge, which might be an easier medication to get. So if somebody is not able to come in for their lenacapavir injection, we would recommend taking 2 pills of TDF-FTC. On the first day, they're supposed to bridge and then keep taking the pills daily. If more than 28 weeks have passed since the last injection, so more than 2 weeks after their scheduled injection, you have to restart Len. So restart with the pills, restart with the injection. So 28 weeks after the last injection, which I'll show you the calendar in a second. Navigating cost and coverage. So here is the scope of it. The injections are really expensive, and no one's going to say they're not. I think we'll see where this goes if we can get these drug prices down over time. But they're expensive. I think, especially comparatively to oral TDF-FTC. The big important thing with the injectable medication is the first step is figuring out how the insurance is going to pay for it. So whether it's under a pharmacy benefit or a medical benefit, this can mean various things for your practice. Pharmacy benefit means that it's coming from a specialty pharmacy outside of your clinic or your hospital. So the insurance is paying for the drug like you would pay for any other drug that you're sent to a pharmacy. The medical benefit means that it's bundled in the PrEP visit. So it's purchased by a medical facility and then administered like a vaccine within the visit. So various institutions have various policies on this. It can benefit you or not benefit you to do different things. This is a course in and of itself, but this is the important distinction to make as soon as you want to figure out if this is a reasonable thing for the patient. So if your facility is not able to do a medical benefit and that's all the insurance will pay for, then this is not an option for the patient at this time. I will say also, for folks that are uninsured, we just figured out how to use the advancing access through Gilead to get folks who are uninsured onto Len. We got our first delivery today. It comes in a nice FedEx box. So it seems like the standards are pretty much the same for getting lenacapavir for folks who are uninsured from the drug company. You have to be uninsured and you have to be 500% above the federal. Monitoring retention. So if you go to the Blueprint website and you look for digital tools, you'll find this injection calendar. So this is something, it might seem like you don't need it, but it's actually kind of handy. So lenacapavir is administered once every 26 weeks, and the window period is 2 weeks before and 2 weeks after. So while we recommend coming in at the 3-month mark for STI testing, it's important to know when they have to come back for their injection. So this is just a little schematic of when somebody puts their date in and what you can get back to print out for the patient if they want to know what their window period is. A lot of clinics we've talked to have said, well, I don't have my templates built for 2026 yet. Heard. So if you give the patient this calculator, make sure they are aware of how they can calculate when they need to come in for their injection. There's various ways that you can use a calculator, maybe with your front desk staff that isn't so savvy in understanding that the window period. You can give them this calendar. There's a bunch of different ways to use it, but it is available to you on this website below. So again, if more than 28 weeks have passed since the last injection, So more than 2 weeks after the scheduled injection date, you have to restart with the pills and the injectable medication. Here is our follow-up visit schedule. I think pretty similar for Len. The only thing that I would maybe not, no, I would do all the same. So the thing that's kind of falling out of favor, because we know that lenacapavir and cabotegravir are so preventative, they prevent almost 100% HIV transmission, is the NAT. And I know this was a big thing everyone was saying before, it was like very expensive for folks to have to purchase. I think if you're worried about acute HIV infection in any way with somebody, then ordering the NAT makes sense. Prior to the first injection makes sense. If they've missed an injection, that makes sense, but ordering it in a screening way is probably not necessary anymore, which is cost saving and fantastic. We've also gotten some questions about, like, even is the HIV test necessary if somebody's coming in for their 3-month visit for their lenacapavir and they just had it 3 months ago. I think you're going to find that a lot of patients still want that HIV test. I think it's part of routine. We've spent a very long time trying to make sure people were doing HIV testing. To say that somebody doesn't need it seems like a culture shift. So I think while we can rely on this medication being very, very effective, I still think ordering an HIV test, obviously at baseline, but every 3 months makes sense. And that is what I have, guys. Yay!
Great. Thank you so much, Karen, for that wonderful presentation. We have a couple questions here. There was some that came in yesterday. If a patient tests negative for HIV but is in the window period, can you go ahead and start PrEP after the initial negative test, or do you need to wait and perform a viral load?
Great question. I would make sure to get so did they give a sexual history? Did they say when they were exposed?
It does not mention that,
Okay.
but I defer to you for interpretation.
Yes. Okay. So I would say for somebody who comes in to see me and says, I had sex yesterday, I want to start PrEP. And I am also worried about HIV. I think make sure you have a very good phone number. Make sure you know how to get in touch with that patient. And my threshold for letting somebody leave with Truvada is it's incredibly low, because I feel like there's so much good data on showing that if people are forced to come back for their prescription, they won't come back. So I'll do an HIV test, 4th gen. Usually that takes 24 hours. I usually send them home with their prescription or with the pills and say, I'm going to call you tomorrow and tell you which ones if you have to come back in or take these pills. Because it was yesterday, I might not know right away. So I want to make sure that they come back in a week. But the data is just too forceful that making sure somebody walks away with a prescription is incredibly important.
Would you mind clarifying if Truvada Daily is approved for women or if it's just Descovy?
So it depends what you mean by approved. Truvada Daily has been approved and studied in cis women. Descovy has been studied as part of an arm of a clinical trial for the PrEP trials. And Gilead's put out data recently showing that it was as effective. We do not have the 20 years of clinical trial data that we have with Truvada. Unfortunately, I would love to say only Truvada for cis women. I can't say that because Gilead has made Truvada unavailable via their advancing access program. So if I have an uninsured cis woman who wants to start PrEP and I have to go through Gilead, I need to give them Descovy. It probably works. I make sure to have this conversation with them. I say, we have this one trial and, this is better than nothing. Make sure they come in frequently for their STI testing and their HIV testing. And that's the best we can do right now. Unless they want to pay for generic Truvada out of pocket, which is definitely a possibility, but it's $30 a month-ish.
Can you talk more about any weight-based dosage concerns and any issues with the amount of abdominal adiposity with Len?
Great question. So, with CAB, we have a totally different protocol for folks that are obese. There's a different needle. There's a lot of different with Cabenuva especially. There's a different way we're giving it. Lenacapavir, there's no guidance around different adipose tissue. We don't have any information as of yet if someone is morbidly obese, what the difference is. But we will find out soon.
Can you comment? Oh, did
Yeah.
you want to add anything?
No, that's
Okay.
great. Thank you so much.
Can you comment on lenacapavir's safety in pregnancy? Is there any data yet from registrational trials?
So they included pregnant women in the clinical trials for purpose. There's very good data on lenacapavir being well tolerated during pregnancy, in the purpose trials. The thing that was different was the abdomen. So that's where they started using the thigh. That's why they added the thigh to the package insert, was because for pregnant women or people who are in their final stages of pregnancy, like they can get their injections in their belly. So they got them in their thigh.
Great. How does patient candidacy differ for injectable CAB versus LEN? Who do you recommend one to versus the other?
So like I kind of started with, I kind of give them all the options. And if somebody says to me, like usually you can find out in the first 5 minutes when they're like, I don't want to do any pills. Like, okay, so let's talk about the injectables. Great. I travel a lot for work and I'm never around. And coming to appointments is really difficult. And, I try, like, we have a lot of people who work in traveling Broadway shows. Um, Sending Truvada to a random theater in Kansas is a lot easier than me figuring out how to get them Apertude in Kansas. So I think a conversation about insurance, lifestyle, side effects, frequency of visits, all of that is encompassed in the conversation about what PrEP they want to choose. And I definitely don't make it about I make it about what would benefit them the most, because then it's coming from them.
Do you recommend PrEP or something similar for serodiscordant sexual partners?
100%. But I run a sexual health clinic, so I am not privy to a lot of what's happening with their partners. And the negative patient in front of me, if they say, well, my partner's undetectable, I usually ask, how do you know that? And I do a little relationship check for them and say, like, do you want to have something that you're in control of, that you're making sure that you are taking in order to prevent you from getting HIV from your partner? Um, the partners trial was amazing. I think the chances of transmitting HIV if somebody's undetectable is nil. But I think for some patients, especially patients who are new to the relationship, I think having a PrEP regimen on board can offer a lot of relief. And I think now, especially that daily TDF-FTC is so inexpensive, I don't think it is out of the realm of possibility that somebody should take that on top of their partner being undetected. Um,
How are your patients reacting to injectable PrEP options versus the oral options?
I guess I need more information. They're very excited. Well, okay. I thought everyone was gonna like run to the door with Len. The nodules, they're not so excited about. They like their flat bellies. So like I thought we have 20 people on the wait list now, but well, when I say wait list, we were waiting for Medicaid to get approved in New York. And now it's approved. So people are trickling in with Len. Cab, we have about 100 people. I thought people would want to jump off of cab faster onto Len, but I'm not seeing that as much as I thought. I think everyone gets a little bit hesitant about a new regimen or a new modality. They want to see how it absorbs in the community first. But the people who have gotten it from us, Len from us, are raving about it. They're so excited. They're like, this nodule's nothing. I can't believe we talked about it for so long. And I'll see you in 6 months.
Going back to the example of the patient commented on before about starting PrEP immediately.
Yeah.
So what if the patient is positive after taking PrEP, but it wasn't detected on the first test and left with PrEP?
We have seen in our years of PrEP administration very if somebody is taking Truvada for a week or 2 weeks after an HIV diagnosis, that is not long enough to develop a significant M184B resistant virus. So that's why I said make sure you have a good phone number. You don't want somebody on Truvada and be HIV positive and on a mono regimen for months. That is not a good idea. But I think a week or even a couple days, I am not concerned at all. And I'd rather weigh the risk of somebody making sure that they have a PrEP, being HIV negative and making sure they have a PrEP regimen on board than a couple days of a medication in the presence of HIV virus.
Do you have any thoughts on why HIV rates are increasing despite these effective therapies being available and used?
Because we're not hitting the populations with PrEP that we need to. We're not, I mean, my first couple slides were, we've historically done a very, very poor job as a public health community in engaging Black and Latinx folks in sexual healthcare, but sexual healthcare in general. And I think this disparity is just going to increase if we continue down the road we're on. I think having providers who are able to provide comprehensive sexual health care, but also have a frank and honest and client-centered way of talking to patients about their sex lives. I think those folks are few and far between. And the amount of people who I see in my clinic when I ask them, like, tell me about your sex life, and they say, no one's ever asked me that, and I'm 4 years old. I think that right there is the reason why we are where we are. That and all the cuts, but
Can you talk more about ketamine and lenacapavir? How do you make a shared decision with the patient on navigating options?
yeah, so I'll just tell you about a patient the other day. They go out and use club drugs. We mentioned ketamine. They said they didn't know it was in their drugs, maybe ketamine. They're not sure. They want Len. I like, I don't want to gatekeep a medication from somebody who is insisting that they will be more responsible with their ketamine use. I think if somebody is on ketamine for chronic depression or wants to start ketamine for chronic depression, like that conversation needs to happen before Len goes in the body. But we were kind of hit with a little bit of a like, this person wants Len more than anything else, and they're not taking their oral regimen. And they are a sex worker. So it's one of those great things we get to do as providers is figuring out, pros and cons. They were like, I understand that ketamine is a interaction. I am understanding of that, and I will try my best to avoid it. There's only so much you can do, I guess, but I think their HIV risk is actually higher than the interactions with ketamine, but they haven't started yet. We're still on the fence about how to handle it.
This question touches on telemedicine. Do you do initial or follow-up visits through telehealth as a means to cover this gap in healthcare access?
We do. I don't love telehealth for PrEP because I usually want STI testing when I'm with that person. And our clinic, getting labs sent to a Quest or a LabCorp is pretty difficult for folks who don't have insurance and also need 3-site testing. But we have a care coordinator model in our clinic PrEP. So everyone's assigned a care coordinator, and that is their point person for all PrEP related questions or problems or lack of access. So everyone is assigned that person. They have their cell phone, they text back and forth, and they can come in for screening and have a conversation with me, or not have a conversation with me, but have a conversation with their care coordinator. That's the model we've driven. I think it works really, really well. We have not had the best luck with telehealth because we always want 3-site testing, and getting that outside of our clinic is difficult.
What are you most excited about for Len, and what are you most concerned about?
I'll end with what I'm most excited about. What I'm most concerned about is these the lack of data we have about its interaction with erectile dysfunction drugs. A lot of the people we take care of use like erectile dysfunction drugs or use like erectile enhancement medication that I don't know about. So I don't know what that's going to look like. And asking someone to choose between their ability to enjoy sex more and an HIV prevention modality makes me angry in my body. But we'll see. We'll see really soon what that's going to look like. But I think, I came into Len in June just being like, let's go, everyone gets it. And then I was like, wait, what? Like this? So I think that's the thing that I'm most concerned about, and also just like, really? Well, I hope it's not, I hope it's anecdotal. I hope it's not as real as it's the WHO says it is. And what I'm most excited about. So I think I kind of touched on this a little bit with the the tail for Len. I think this is our moment to provide PrEP to folks who are unhoused or who are substance using, who don't want to come into a clinic place. I think this is the drug. This is the moment. I think we had it with Cabalet a little bit. The data coming out of San Francisco is amazing around providing this medication to folks who are traditionally not able to come into a hospital setting. But I think with Len and the lack of the need to preserve a drug class for HIV treatment, I think as intently as we have with Cabalet, I think for Len, this is the drug that we should be using on all our mobile medical units, on all our pop-ups. I think if we go big or go home, this could make a huge difference for the city and for the United States.
Great, thank you for that. Can you talk more about baseline testing for PrEP?
Sure.
And share more about the nuances between oral and long-acting options.
Right. Okay. So if I have a new patient never touched PrEP and they're coming in to start PrEP, I'm most likely not starting them on an injectable regimen because that takes a little bit of work. So I'm going to do an HIV test, an antibody antigen for 4th gen. I'll do 3-site gonorrhea and chlamydia testing. I do a syphilis test, and I do Hep A, B, and C screening and testing as well. I check liver and I check kidneys the first visit. So I do a BMP and an LFT. If I start them on an oral regimen then, and I work on their prior authorizations and stuff for the injectables. So they're protected while I am trying to figure out if their insurance will pay for the injectable. When the person comes in for the injectable medication, a week, 2 weeks later, I ask them if they had sex in the last 2 weeks, if they've taken their PrEP in the last 2 weeks. If either of those answers are fuzzy, I might do another HIV test right then. 2 weeks, I might just do it anyway. And then we give them their injectable medication.
All right. Thank you so much, Carrie, for that excellent presentation and Q&A section.
Thanks, guys. This is fun.
Yes. We are now going to take about a 20-minute break, and we will resume with STIs 102 starting at 11:10. Thank you.